So wanted to just thank Dr. Corin. You know, last time we spoke, we talked about going into practice and some of the issues there. Dr. Corin has a little bit of a different perspective. And so I thought that it made sense for him to give you his perspective on training and or going into practice after training and some of the things to think about. And you know, we can make this participatory. And
Yeah, that'd be great.
so thank you.
So be interactive, no problem. So I'm a cardiologist. I'm the director of the heart program, the Heart Institute. But my background, and I wrote What Do I Know About This, is that I actually was in private practice for a long time. I was the third in a practice. We grew to 28, and I ran the practice for a long time. Then I started a medical consulting company where we did managed care consulting. Did that for a number of years, and then I was recruited to come here and do stuff, and so now my jobs are sort of different here. So I have a perspective of hiring docs and working to employ physicians from the time we were 3 to 28. I pretty much interviewed and hired all those docs. And then in our current practice and the Heart Institute, obviously that's what we do, part of what I do. So, and I tend to be a person that the fellows come to and say, hey, what do you think of this job? What do you think of this contract? So I put a little talk together a couple of years ago to sort of help you guys. Now, crit care is a little bit different than, say, cardiology, but I just threw that out there. No, it's not water using to retaining food. That's what I get. So we're going to talk about 3 different things, okay? You don't see that in crit care. We see that in the office. I don't know, I think I'm retaining water. No, you're actually. So, three types of practices to talk about, and three things to review really here. One is, what kind of practice are you considering to join? Are you guys both you're both first year fellows? You have one more year, right? And there are a few people on the thing that may be getting closer to looking at this process. But you know, the question is really, when you join a practice, is it academic, a private practice, or hybrid, which we'll get into, and you have to decide which one is right for you. And then we'll talk a little bit about what are the goals for your first 5 years after training, what are the things you should be thinking about, and then a little bit of talk about how you should approach your contract and what are the things to think about. You know, we spend so many years training, we spend so many years thinking about what we want to do, that when you finally get close to the finish line, you're like, okay, now what, right? So this is sort of to help get you a little bit thinking about the different types of practices that are out there and how you should start to think. So in academic practice, and you know, the strict academic practice is going away to a large degree. Funded practices or funded jobs, but there is still a role for research funded or endowment funded. What is endowment funded? Endowment is, you might see the so-and-so professor of medicine or so-and-so professor of crit care. That's usually someone who had an experience, gave money, set up an endowment, and that endowment helps fund that person's salary to a large degree. We don't have a lot of that at Cooper, right? But if you go to other academic institutions, you might see 5 or 6 or 7 people, say in the division of crit care medicine or in cardiology, that have that. And that means that a portion of their salary is funded so that they can do other things and not just see patients. Teaching, obviously, in academic practice is an opportunity. Publishing, obviously, and obviously take care of patients. So you're going to be taking care of patients in academic practice, probably less so than someone who's in private practice or even a hybrid practice, which we'll talk about. And then in an academic practice, you're always opening up the door for opportunities to change what you do, plus also consider sort of hospital administration or other academic appointments or opportunities. Hi, guys. Welcome. So we're talking about what opportunities there are as you look forward to finishing your training, and what some of my thoughts about how to go about it and what are the opportunities for you guys. So we're first start talking about academic practices. Second thing is private practice. So private practice, and there are still crit care private practices that are mostly contracted by healthcare systems to be independent groups, or they just work independently in big health systems or smaller health systems. And they're really private practice. And then what is a private practice? Private practice, doctors own their own practice, whatever that might mean. In crit care, it's not as much building, it's not as much an office, it's not as much as, but you might be, I don't know, some of you might be cardiologists that are also crit care doctors, or you might be anesthesia that's crit care, and you might join an anesthesia group that has an ownership in, say, a surgical center, and that would be an opportunity. That's private practice. We've always thought about private practice as being able to sort of self-determine, sort of be your own boss, manage your own business, and ultimately you become an employee and then a partner in a private group. And that ownership that you have gives you some self-determination. You feel like you, by owning a practice or owning a part of a practice, have some degree of self-determination. Changing a little bit in the world that we're in now, because with the larger healthcare systems, it's harder to be in private practice and exist. The big thing now in private practice is large private practices, and you should keep this in mind as you interview, are becoming very attractive for private equity. You know what private equity is? Okay, private equity is Wall Street money, and Wall Street money is out there big time looking at private physician groups that are profitable. So they started with dermatology and ophthalmology that are typically not hospital-based, but they make a lot of money because they do a lot of procedures in centers. And ophthalmologists, similarly, they work in ambulatory surgical centers. They might own a piece. And private equity is big money out there that's funded by either large funds or individuals, and they put together money and they go to a group like ABC Group, ENT and Allergy Associates. They say, hey, listen, you're a big group. We want to be your partner. So what they do is they come along and they buy 50% of the practice. And they buy 50% of the practice. The physicians still own the rest of the practice. The docs that are partners get a big check, like a real check, not not like your annual salary, but like a big check. And then they get a diminutive salary over the next few years. So what that means is, let's just say the doc's making $500,000 a year. They might throw you a check for, I don't know, $1.5 million, and they say, here's $1.5 million. Wow. And $2 million. And for that, we're going to reduce your salary by 20% per year for the next 5 to 10 years. So essentially you're paying it back, but you get it up front. And then you own shares in the larger company. So let's say they're putting together 20 crit care practices, 20 ENT practices. Now that new entity has a value. And if they manage you correctly and they go to the insurance companies and get you premium rates, or they build a new ambulatory surgical center that you couldn't do on your own because now they have the backing to do so, and they make you more money in 5-10 years, those shares might have a value. And so that value might be a publicly traded company, or it may end up being another entity. So that's really big in the world that we're in right now. So there are a few private groups that are left in South Jersey as an example. I know 2 of them that are actively negotiating with private equity firms to be acquired. So that's something new in the last few years. The advantage of private equity is they can pay a lot more money than a hospital system would to buy a group. Because a hospital, we're restricted by the laws of Medicare and restrictions of incentive to refer. So when a hospital or a health system buys a practice, it's a very formula-driven way of doing things, and there's not a huge amount of money in it for the doc joining what's in it for the doc joining the health system is a steady flow of patients and maybe some, and I'll go into some of that in a little bit about a hybrid type model. But what happens is when you join your own group, my point is that what private practice is 10 years ago and what it is today may not be the same. So for example, if you join a group that seems economically very sound, you might join as an associate, become a partner in 3 years or so, whatever the rules are. And you may find that they've been negotiating, or they start negotiating with a private equity group, in which case the partners usually get a large share of the money, and you may not end up with all that money. And you're not in a position to negotiate that. Does that make sense? Anybody have any questions about that? No? It's kind of a little abstract thought, right? But that's so, when you're in private practice, you have to manage the perils of the future, and you have to manage the perils of the health system that you work with. So let's just pick an example. You work for, you guys go to Inspira, the attendings go to Inspira. Do you guys rotate through Inspira? No, none of you guys do. But let's just say Inspira gets bought by Robert Wood Johnson. It's not happening. That's just theory. So now all of a sudden, if you're a private group and you're working there, let's say you're a private group and you're working there, they may come along and say, no, now the ICUs are all full-time and they're all, what do you really own, right? So the idea of private practice is a little bit not what it used to be, because the health systems have more and more power. Why? Because the health systems are employing more and more of the physicians. The health systems are really the ones who are putting at risk their employed model and their healthcare delivery system. And so their private groups are more beholden to the healthcare systems. Now, there are geographic areas in this country where that may not be the case. So there may be large critical care practices that employ all the docs in all the hospitals in Oklahoma, in which case they're very, very strong, and they're stronger than the health system because the health system can't recruit that many good crit care doctors. So every state is different, every local region is different, but you should just kind of know what's going on. I always tell people that when you're, go ahead.
I was just gonna jump in a sec. So the group around here, Sound Physicians, right? I mean, that's kind of that sort of group who employs a lot of critical care docs in a lot of hospitals. But understand, if you work for them and the contract doesn't go well, the hospital's unhappy with their outcomes, right? That's you out. And you probably in your contract have a clause that says you can't work there if they lose the contract.
Right.
So you do have to just be aware of that. And some of the EM groups also have, right, they're contracted groups.
Around here we have that. So Team Health, for example, is
Yeah.
contracted, big national group, and they're contracted at Inspira, and they do all the Inspira ED. They're not employed physicians. But what happens in 3 years from now? I think to your point, that's a good point, because what if they come along and say, you're out? Then they come and offer you a contract. You have to make sure that your original contract doesn't prevent you from doing so. It's important, otherwise you have to move, right? Usually, and we'll talk a little bit about restrictive covenants and what they typically mean, but I always tell people in private practice, you really, I mean, you always want to like the people you work with, but when you're in business with somebody and you're sharing a business model, you really have to like them and trust them to a larger degree than not. The hybrid model, which is really I would call our Cooper system more of a hybrid model, not a true academic model, because we are all employed by the healthcare system, right? And we get paid based on productivity as a group and as individuals. And the vast majority of docs in Cooper are in some type of a comp plan model. And most healthcare systems now are in a comp plan model. RVU is just a way that Medicare created a system to put a value to what you do. So as an example, if you do a heart catheterization, that may be valued at 4.5 RVUs. If you read an echo, for me, it might be 1 RVU. If you spend an hour seeing a patient in the ICU, it might be 3 RVUs. So it's a system that was developed to create an objective assessment of how much money you should get paid for the work you do. If you do an appendectomy, it's X number of RVUs. So we're all driven by sort of productivity. But the nice thing about it is that you don't have to worry about billing or collecting. We're insurance agnostic, which means that we never look and see whether someone has insurance or doesn't, because we're just doctors taking care of people. It may affect how they take care of themselves when they leave and their prescription plans and things like that. But the advantage to us is that we don't have to worry about insurance. We don't have to worry about billing. We don't have to worry about overhead. We don't have to worry about insurance billing companies, contracts, things like that. By the way, what do you think the best payer for doctors at Cooper is? You think it's, I'm gonna throw out something, you don't know the answer, but let's just, you have Medicaid, which is the state, right? You have, so these are lesser economic patients or have disability. Medicare, typical Medicare, which is 65 and over. Someone like who has Horizon, we have, I guess, Cooper Horizon now, is that what we have? What's our insurance, Horizon? I think it's Horizon. It's administered by Horizon. There's AmeriHealth and there's United. Which one do you think, for the work that Dr. Spevitz does on a daily basis, do you think she gets more dollars, not RVUs, more dollars per RVU, not she, but the system, but she's not getting she's getting, we all get paid per RVU, we don't get paid based on insurance. Which one do you think is our best payer?
Horizon.
Who answered? Horizon? You think Horizon? Horizon. Okay, so at Cooper, our best payer is Medicaid. Why is it our best payer? It's for doctors, okay, for doctors. Our best payer is Medicaid. Why? 20 years ago, the state of New Jersey realized, and based on the lobbying of academic medical centers, that patients with Medicaid were not getting in to see doctors because doctors in the community weren't going to get paid $8 to see a patient when they could get $40 to say from an insurance company. So they came along and said, you know, we're getting screwed. We accept Medicaid, and we're really the ones bearing the economic burden of taking care of these people. So the state of New Jersey created a program and said that if you're an academic medical center in the state of New Jersey, so it's us, Robert Wood, SOM, and Newark Beth Israel, we get, it's called MAPS money, MAPPS money, and that MAPS money makes Medicaid, believe it or not, our highest payer. Now that's irrelevant to you guys. It's not relevant to us taking care of patients every day, but it's relevant to Cooper. It's relevant to the academic medical centers that bear the burden of taking care of the underserved in the state. Anyway, that's an aside. It has nothing to do with wine. When you're in a hybrid model, do you really have control of your job? You have a control. You can take a management role. There are people in care in your department that have management role you can have, but you really often, are you just a cog in a wheel? And I would argue the answer should be no, because no matter what opportunity you take, there's always opportunity to advance yourself, both in terms of leadership, clinical expertise, or something new you bring to whatever practice it is. Oh, I'm stuck. Oh, well.
There you go.
Okay. Oh, I skipped a bunch. All right. Hybrid model. Here we go. So, what are the goals in your first few years? And I think you shouldn't. My point is going to be that you're not stuck no matter where you go. That your skill set is yours. My father would always tell me that your business is your brains, and with your brains and your skills, your training and your knowledge, you can pick that up and go somewhere else, assuming that you're not contractually obligated to stay in one location for beyond a certain time or have a restriction. But you should always have goals in mind, whether you go into one of those three options, which is academic, hybrid, or private, and you should think about what you want to do. And these are some ideas that you should just think about. If you join an academic practice, you should always think about academic advancement. What are the things I could do to become an instructor of medicine, assistant professor, associate professor, professor of medicine? That always will help you in your academic role. People will respect you. People will look at you differently. You'll be publishing. You'll be nationally recognized, locally recognized. And if you ever want to leave, that is definitely a feather in your cap. So you want to have people know that you're really a good doc and know what you're doing. I do suggest that you pick a senior mentor no matter where you go, and pick someone who in that practice that you want to model yourself after, at least learn. If it's not one person, it might be 2 or 3 people, and you blend that. You're doing that right now as you train. You're picking up little pieces from each person and how they practice. But in terms of goals and how they move themselves forward, say, oh, that person, she really has done a lot, and I'm going to ask her what she did or how she did it. Develop your practice style, teaching, start publishing, and then the question is always, are you well trained enough? Do you need more training? Is there something else you want to specialize in? And I think until life bogs you down, the first 5 years are really the easiest time to do it. If you're in private practice or hybrid, I put them together really. It's really similar, but I think, you know, when you're in private practice or in that hybrid model, particularly if you're in the community, you really want to create a reputation for yourself and make sure that everyone recognizes who you are, what kind of person you are, what kind of doctor you are, how you communicate with staff, how you communicate with patients, how do you communicate with your colleagues, and really establish that reputation and start to put roots in the ground in the healthcare system, whether it's committees that you are on or whether it's in the community and church organization or religious organizations that you may be part of, and start really sort of developing what, you know, in the first few years, if this is where you want to be, what do you want it to look like as you move forward? And really develop a business acumen, try to understand some of those things, try to understand how we get paid, how we bill and collect. What does the insurance landscape look like? There are some people who have no interest in it, some people have tremendous, but really start to think about your first 5 years. I tell people this all the time, you're not stuck, right? You're not stuck. You have the opportunity to regroup no matter where you go. Remember, we are still the numerators. I always say this to all our colleagues. We are, if it wasn't for us and the patients, there would be nothing here. Why? Because we are what provide the care. Every administrator, me included, can go away tomorrow. But at the end of the day, if we're taking care of the sick patients, we're taking care of the well patients, all the billing goes through us as providers, as docs, you know? So remember that you're still the commodity. You remain, don't let it get to your head too much, but you are the commodity. You remain the commodity. You remain the respected person. You know, Tresiak would always say, I meet people on the worst day of their life. He used to say, I used to hear him all the time say that because they're in the ICU. But at the end of the day, you are the one that these people are looking for, and they're seeking your expertise, and you remain the commodity. So no matter where you go, if you're not happy after a number of years, I think in the current system, you can pick up and leave. You can go somewhere else. And your skill set transfers. And the one thing that's different today, that because there was such a large private practice model in the past, when you would do private practice, you would start out at a lower salary, right? And then you would build your way up and you became a partner. And as you're a partner, you're making a larger piece of the pie. Nowadays, that doesn't happen as much. People are coming out of training and they're making more money to start, and there's not a lot of this partnership thing. If there is a large partnership thing, be skeptical, understand that, like I talked about earlier, they could be bought by private equity in the future, and they may ultimately have to fold in and become employed because they're vulnerable to the healthcare system that they provide service to. On the other hand, like, what's the guy's name who left and went to Texas? He ran a big private group, right? What's the guy? Serge. Didn't Serge do that for a while?
Yeah, that's the Sound Physicians.
Oh, he's Sound Physicians, yeah. So I didn't realize he was in that group, yeah. So like, but still, Sound Physicians might be a very excellent private equity target in the next 3 to 5 years. Ask about your restrictions, right? So restrictive covenants, which we'll talk just briefly a little bit about. When you decide what you want to do and someone hands you a contract, you should think about, before you look at the contract, what are your goals and needs? Like what's important to you? And I always say, ask others before you, which means if you're joining a large group, let's say you're joining the Cooper group, ask the 3 or 4 most recent hirees, how are you being treated? How do you like it? Are you happy with your decision? Why are you happy? What do you have regrets? Look at the stability of the institution. So what I mean by that is, this is really, can't emphasize this enough. You look around and you see practices and healthcare systems growing, buying other healthcare systems. Everything seems wonderful, and then all of a sudden the bottom falls out. Most like if you look most recently, you had hospitals in Pennsylvania. There were a couple of hospitals that literally closed down. They closed down. They closed the doors. And I assume those docs are being absorbed somewhere else in the system. But you know, the stability of the healthcare system, delivery system, is really a big, especially in your jobs. You know, you don't have an office full of patients. You have an ICU full of patients. And the ICU full of patients depends on whether the ICU is open or not, right?
Yeah, that's
So-
becoming more common these
Yeah.
days. Like that used to be like, really, the hospital's gonna close,
They do.
right? And now,
They
really, the
close.
hospital's closed.
Chester Crozier, okay,
Yes,
big
that's what I
healthcare
was gonna
system,
say.
huge healthcare in Chester, New Jersey, Chester, Pennsylvania. They were closing, had a million problems. Christiana was gonna buy them, and then Christiana just pulled out. So now, right now, there's no plan. I just got a call from a heart surgeon there who says, "Are you guys hiring?" Right? So, like, could you imagine? You spent your whole career in a healthcare delivery system, and you think, "Oh yeah, you know, it's never gonna," and it closes right in front of you. And all of a sudden now you're like, where am I gonna go? You'll land because you have no restrictions at that point and you'll find the job if you have a good reputation and everyone knows you do a good job and the nurses all love you and all this stuff. You'll find a job, but it's really disruptive. You know, it's really disruptive. So the health of an organization is really important. And so, you know, I think one of the reasons I took a full-time position at Cooper is I believed in the health of this organization, right? I also believed in its commitment to physicians and its commitment to physicians' growth, as opposed to other systems that may not have that same way of doing things. Um, if people have left, if colleagues of yours have left before, try to find out why. Say, why did so-and-so leave? Or maybe you can contact that person, or maybe you can ask someone else younger, say, why did they leave? And usually there's a good reason. You know, maybe a spouse and relocation, maybe it's a family illness, maybe there's probably good reason, but if you see a lot of turnover, be very suspicious.
And make sure you ask those questions.
Yeah, yeah.
Right? I mean, for critical care here as an example, like no one has left in the last umpteen years, really, right? The Cancer Institute, if you ask over there are a few people who have been there more than
5 years.
5 years.
Yeah.
So, you know, again, do
Yeah.
your homework.
Do your homework. And so that's within the same institution, right? Healthcare delivery system. There's, you know, it usually comes down to leadership, and it usually comes down to sort of how we treat colleagues, right? Everyone treats each other. But again, there's other independent factors. It could be money. It could be lack of advancement. It could be I get the short end of the schedule stick. You know, I'm on every holiday and it's not fair, or I get dumped on, or, you know, I always have the really sick service and I don't get out till 9 o'clock. You know, it's a lot of things, right? I mean, if you like the job, you have to sort of think about whether you want to do a hard or soft negotiating approach. What do I mean by hard and soft? There's not a lot of negotiating these days. Most of the contracts are pretty close to the way they're going to be. But be prepared. So soft negotiation, and we'll talk about some of the things that you can negotiate for, is certainly reasonable. The hard negotiation is usually not productive. What I mean by that is, I need this, I need this, I need this. As an example, we were negotiating with a group of cardiologists to join us from another healthcare system, and we were going really, everything was going along really well. And then they came in with a list. Everyone wanted their own secretary, they wanted their own nurse, they all wanted their own nurse practitioner. They came with these demands of stuff, and I said, like, I don't have that. And I'm like, I don't have that. Like, you're asking for stuff I don't have. I said, you should join us and then get busy. And as you get busier, we'll hire people for you. You don't hear people complaining. It was a really distasteful approach to negotiating. And frankly, it poisoned the well, because it really taught me that these people weren't interested in working hard. They were interested in hardly working, right? So what's in a contract to negotiate? So a few things. Obviously the salary, that's, you know, you can negotiate your salary to some degree. And salaries are going up. I mean, the good news is that you guys are going to be in demand. So critical care docs are very much in demand in this country. I know there are cardiologists that are like crazy demand. I came out of training a lot of years ago. I got paid $130,000 a year. That was a lot of money back in 1991. 30 years now. It's scary. Cardiologists coming out of training now are making 3 times that. Now, the difference based on the models that we discussed is that the current model is higher, but it's fairly flat. Going up, you'll go up, but you won't go up to where I started here and went, like after 2 or 3 years, I went way up because I was in private practice. And the model back then was you hire docs in private practice, they work for you for 2, 3, 4 years, you make money off of them. And so you're making more money and that system kind of can, as long as you retire doctors and hire doctors, that system is very profitable. Nowadays, it's hard to do that, right? So docs coming out of training want to get paid higher and you're going to get paid a lot more money. So there's some salary negotiation. Benefits, it's pretty straightforward. Sometimes you can negotiate certain benefits if you had, I don't know, a child with specific needs or a spouse with specific needs. That's come up a few times. Pension profit sharing contributions, support for education and conferences, stipends for car allowances, expenses related to phones, moving expenses. Big thing now is loan forgiveness, not just by the federal government. I mean, for practices and healthcare, if they really want to track you, if you have a large loan, there's opportunities for loan forgiveness. So you should ask that if you have big loans, depending where you're going. If you're joining a private practice, how many years to partnership, and then really the restrictive covenant. So the restrictive covenant, what does that mean? It's a portion of your contract that's designated to tell you that if you were to leave, what would happen, right? So usually there's a time period. Time period means you have to let us know for 6 months ahead of time that you want to leave so that your contract said that. And then there's a time where you're geographically restricted. So most contracts in this area now, 10 miles 1 year. 10 miles 1 year. What does that mean? If I leave Cooper tomorrow, I can't. I have to give 6 months notice. So now they give 6 months notice. I can stay here, I work here. Or they could say leave, but they'd have to pay me for the next 6 months. I leave after 6 months. The next year, I cannot work within 10 miles of Cooper. That includes Philadelphia, anything as the crow flies. Restrictions are not driving. It's not Waze. It's actually as the crow flies. So for example, there's a doc from Virtua who's looking to join us. If he were to join us, he has a 10-mile restriction. He would have to work somewhere beyond the 10-mile restriction for 1 year if we hire him, or sit on the sidelines for a year, right? So that's generally it is. Rarely do you see money restriction. Used to be we'd see this a lot where it's like, okay, you pay us $200,000, you get out of your restriction. They've taken that out of almost, I haven't seen one contract where there's money. Sometimes you can negotiate that. So for example, let's say you decide you want to go to, I don't know, let's say you join Cooper faculty and you want to go to Jefferson, but you're going to become like a program director at Jefferson, whereas here you're a faculty person. And you come to Cooper and say, listen, I really want to leave. I think a place like Cooper would probably negotiate with Jefferson and say, pay us a certain amount of money. We'll let him out of his or her restrictive covenant. You can leave and then money would exchange hands. Why would exchange hands? Because it's precedent setting. So there's got to be something tangible. Otherwise, everyone would leave. Or everyone would have no restrictive covenant. Do we all have restrictive covenants at Cooper?
That's what I was just thinking.
The answer is yes. We all do. There's only one group of people right now who do not. And that's Cooper Care Alliance, the CCA guys. This is the new group. That's the CCA group. And they don't have one because they've been in practice, most of them in the area for a long, long time. In order to recruit them, we had no restrictive covenant because, we had no restrictive covenant because they wouldn't come. Because if they're not happy, they want to be able to go to the next health system. But we all have restrictive covenants. How are you? Howdy. Really missed a good time. Just joking. Right? Did they miss a good time? Yeah, it's a really good time. So, the other thing in restrictive covenant is not just the time and the geography, but it's also non-solicitation. So let's just say you went from Temple and came to Cooper, which we had a heart surgeon who Dr. Minicata is an example of a heart surgeon who left Temple, came to Cooper. We thought we would be able to negotiate his restrictive covenant. they said no, and here he is on contract. We have to pay him, and he has to sit with his, surgeons that don't operate are not happy. So we had to sit and figure out a way to get him. So I actually subcontracted him to Harrisburg, to Hershey, and he worked at Hershey. I don't know if you guys knew this. You know Dr. Minicata now, heart surgeon. So he worked at Hershey.
Really?
Yeah, for the last year. I found a place for him to get to do some cases. And they paid us for his time because they loved him and they needed somebody. So he did that. And he came back after a year of restricted covenant. Temple basically did not want to negotiate. It's real. But in that thing is non-solicitation of patients or employees. So for example, let's just say Dr. Minicata, he participated, not to pick on him, but he participated in our CTM&M. He did some Thursday morning cardiology conferences. He might have participated in some of your conferences in the last year, but he wasn't taking care of patients. And he wasn't allowed to solicit patients or employees. So if his assistant wanted to come here this year, he or she would have to reach out to me. We'd have to have a job posted, and he would have to be completely not involved. Or for patients, the same way. If someone who had heart surgery by him wants to find him, if they find him, great. But if he can't call up the patient and say, hey, I heard you need heart surgery again, come back to see me. So these are important.
Just a quick, because obviously, like, I understand for like a heart surgeon, but like,
Yeah.
with critical care, it's not like we take our patients with us. Is it enforced? Like,
Mostly is because it's precedent setting. So it's 1 year is really pretty little. I mean, when I say that in the scheme of things, it used to be 2 years, 3 years, people would fight it. And the reason they do the 1 year, 10 miles is because it's easily enforceable and it's reasonable. So I'll give you an example. There's a cardiologist who send us patients. There are actually two sisters in practice in Cape Regional, right? I don't know if you guys don't round over there. You guys stay here. So one of them joined two men in the group, and she had a 3-year restriction. This is 15 years ago, which meant she couldn't work in Cape May County for 3 whole years. She took them to court, and she said that, different than crit care, but she said, but it's actually some overlap. She said, not only is there a shortage of cardiologists in Cape May County, but there's not one female cardiologist in Cape May County. She won on both accounts, and she ended up having to pay her some back money. So she won. So A, first woman cardiologist in Cape May County, and B, she started her own practice and she competed with these other guys. So there is precedent. There is, I'm not saying maybe as a woman crit care doctor, you might be the only one. I don't know. I'm just saying there is negotiating, and there's also healthcare systems that work well together and others that don't.
And I think most courts won't uphold some of this ridiculous, like a 50-mile radius or a 5-year, a 3-year. It's just it's just ridiculous. But I think that 1 in 10.
Yeah, sticks. Generally, it's been sticking in New Jersey at least. And every state is different, by the way. There are certain states where its restrictions are illegal, Florida's pretty loose with restrictions, meaning it's hard to enforce. States that had a shortage of doctors had a very limited restricted enforceability. New Jersey, there's a million. You step on. Go to Wegmans, you step on a doctor every 5 seconds, right? But especially, yeah. But anyway, but restrictive covenants are important to look at. Important to take seriously. This is my last slide. I figured this would be good for you guys. Couldn't find anything wrong with this one. Maybe he's just lazy. Anyway, that means we couldn't figure it out, right? But do you guys have questions? I don't know. I tried to outline for you guys just some things to think about as you look for jobs and seeing what's out there. You're going to be solicited pretty early in this process. There's a lot of recruiting firms. Don't sign up with a recruiting firm. Let recruiting firms work for you, but don't sign anything with anybody. You're your own agent, and use your own resources. Here, crit care docs that have been out there and look for jobs. You were in practice before too. And then, right, private practice,
Yeah.
right?
Yeah, we've talked a little about that. I mean, do you know how critical care gets paid? So RVUs, everybody know what that stands for, right? Relative Value Unit. And so we are not an RVU.
Yeah, you get paid by time and money.
Yeah,
Time is money.
we get a salary, we have a salary. And then there's a pot of money at the end that it may be a big pot, it may be a small pot. It depends on how the hospital does for that year. And then there are things that get you a piece of the pie or the pot, right? And so some of them are we'll call them civic duties, right? You're teaching, doing your evaluations, I forget all the things that are in there, but like doing the things you're supposed to do, right? So that's a piece of it. There's a piece of publications, like how many things have you done? Have you started a new program? I'm trying to remember the sheet. Things like that, like what have you done to help the group, to further the group, that sort of thing. And then there's the RVU production piece. So you put all that together and you get some percentage of the pot.
Are people individualized or that's the whole group?
That's
People
for
are
each individual
yeah,
person.
yeah.
I don't know how
Yeah.
how much money comes to the group. Like
Gotcha.
that, I don't know how they do it. So some years it's not very significant. Some years it's pretty significant, you know? So you can't depend on the bonus. It's how the hospital does kind of overall. And there were years, I wasn't here then, when Cooper barely could make its payroll. That was what, like
20 years ago,
20 years ago?
2000.
Like, yeah, so people were looking at jobs and this and that. And they've come a long way, right? They just announced a $2 billion expansion. So, you know, when we were talking about, for those of you who came a little later, when we were talking about looking at practices, you know, you really need to do your homework. So we used the advantage or the example of Crozier. I wouldn't be taking a job at Crozier right now. It's too unstable. You know, they tried to have Christiana buy them out and then Christiana backed out. That's not a good sign, right? Tower Health. I wouldn't be taking a job, personally, I wouldn't be taking a job with Tower Health. I mean, they tried to expand all of a sudden when Hahnemann was closing, and they closed down, what, 3 of the hospitals closed? 3 of the hospitals.
Brandywine, a couple other ones.
Brandywine, Jennersville, and
So many other ones.
one more. So, you know, again, do your homework. Critical care is a little different, so sometimes you won't have those restrictions. You know, it's not unheard of for critical care docs to work at more than one spot, because like you said, you don't have a patient base. You just take care of whoever happened to walk in the door. You know, if you work for a large academic center, for instance, Hopkins, because I worked in Maryland for a long time. One of the guys I've known since I started there, he's an anesthesiologist at Hopkins. And he does time at this little place in Havre de Grace, Maryland. Now, if Hopkins officially found out, he's done it for like 30 years, okay? But if they officially found out, like he could be fired, right? Because you're not allowed to work for Hopkins and work for anybody else. For Cooper, you have to, like, I couldn't go to, like we said, Virtua, but I used to help out at Mercy in Philadelphia. They didn't really care. Wasn't the same patient population. I wasn't taking people from West Philadelphia, you know, from Camden to West Philadelphia. So sometimes, you know, you have to kind of look at those, where you are, what do you want to do? But it isn't that uncommon, like I said, for people who do critical care to, you know, work here a little bit and maybe work over there a little bit.
You mean like a moonlighting thing?
Yeah, kind of a moonlighting thing.
Or you could do, what do they call them, where you travel around the country on your
Right,
time
locums.
off. There's several people who still do that.
Yeah.
That's, no one really cares. Look, so, Rincon, isn't he?
Right.
So when he came here, he came from Jefferson, he had a restricted comment, that's why he was at Inspira for an entire year before he can come back here and do neuro ICU.
Yeah.
So he had a full restriction, they enforced it, Jefferson enforced it, so these are things that you kind of have to sort of keep in mind. But a year is not a long time, it sounds like now it seems like a long time, because you know, you got a year of training left, but it's really, in the scheme of life, it's a short period of time. Keep your mind open, start to think about this more and more, just as you get closer to, so every syndrome, everything about how to use pressors, everything about septic shock, you understand, but this is real life in the future, and hopefully, you get to, so take advantage of some of the conferences that might be out there that help you with the economics, and try to understand it. Try to kind of get a feel for it and see what you're interested in doing in the future. Some of you are different disciplines, right? Some are anesthesia, some are ER, so that has a different complexity because the jobs you might take might have some of that, right?
And that time that you're negotiating, that is your best opportunity to kind of make the job what you want it to be. If you want to do half EM and half critical care or whatever, that's the time where you want to do X amount of pulmonary and X amount of sleep and that's the time to really talk about those things.
Yeah, for sure.
Those are things that are important to you.
Sure.
Right? Because that's when you have your little bit of leverage. Because as Dr. Korn said, once you sort of lock in, at Cooper, for instance, we have had, in terms of pay raises, it's been like 2.5%. So 2.5%, it's the same thing that the residents get. It's not different. You guys got more than we did last year. Sometimes it's less. So it's not like your pay is gonna take these gigunda, I made $20,000 more. Now the bonuses are where you get a little variability. So it's important to kind of negotiate that first salary. When I took my first job, I negotiated my first and second year. I think I made 90 the first year and 100 the second year.
There you go.
And had I not negotiated in that 10,000 jump, I would never have gotten that. So those are things to think about. And to the point of the hardball negotiating, it is certainly true that if you're going to work for something like Cooper, the contracts are pretty set. There's some things you can do. Like I negotiated because I live quite a distance away, so I had that removed, that you had to live within whatever it is, 30 miles or whatever. And then I have the place, in Philadelphia. But anyway, so it was out for the first few contracts. But then you get a contract every year, and then people forget that wasn't in there, and all of a sudden it's back in there, and I don't even cross it off anymore. But there is some wiggle room in contracts. I think that it makes sense to pay a lawyer one time to negotiate that contract. It's probably going to be a couple $1,000. To just read over it, to just make sure that you understand what you're signing. Maybe not so much for an entity like Cooper or Jefferson. You can read, it's not that legalese. But if you're doing a private practice,
Yeah,
I would spend the money and have a healthcare attorney read your contract.
Yeah, it'd be nice if it was from the state that you go to.
And it should be from that state because every state has a different rule.
No question about it.
So those are things to kind of think about. When I went to Florida, I negotiated as part of my thing that there was no bronchoscope for me to use because pulmonary had the bronchoscope, so I was in the ICU. So I negotiated that I wanted a bronchoscope bought for the ICU. So like little stuff like that, you can occasionally.
Moving expenses,
Moving expenses, yeah, you can
Like that.
occasionally get.
I did have my first time, interviewed somebody a few weeks ago. He asked me about paternity leave. That was new for me. My paternity leave, the first 2 kids I had, I think was 3 hours. And that's the way it was. But now there's paternity leave, so you have to know what is paternity leave. What do you think it is at Cooper? Not Cooper, the state. Paternity leave. Assuming your spouse or your partner is taking time. So if your spouse is taking maternity or whatever your partner is taking, it's 2 weeks.
What?
It's 2 weeks for paternity leave.
Are you sure? I think it's 12.
I think it's 2, that's what I'm told now. If someone else is taking it. If you're the only provider, let's say, I don't know, if you're a guy and you're married to a woman and woman is taking 12 weeks, you're only allowed to take 2. Now, this is what I was told.
Yeah, check on that because
I have asked Beth Green now to check
some
on
of the
it.
faculty, I happen to know faculty now who's a he, and I don't know anything about what the wife's doing, but he got 12 weeks because it's now become a state.
Yeah, but is she taking off the same, he could take off the next 12 after her.
I didn't even get 12 weeks.
Yeah, I know.
Well, you could have taken 12, but there's the difference between what the state will give you and all of that and your training.
Yeah,
And also that was after I.
Yeah.
but ask around, so if you're a man and that's important to you, ask about maternity is a lot more negotiated and straightforward, but paternity is it's a relatively new thing.
And it depends on it does depend on the state that you're in.
Yeah, and I said, I don't know, find out for you. But,
Please give him good attorney.
we have a generous PTO at Cooper, so, pretty generous, so, but every system is different. Take your time, make sure you have enough time for yourself, that's important.
Yeah.
Any other questions? I hope this is helpful, maybe sparked a couple things in your mind, but, happy to answer any
Any
questions.
of these recruiter groups that we should avoid, that you know of?
Say that again?
These recruiter groups that we should avoid?
I don't know the answer in Crit Care, but I think they're salespeople, they're trying their best, right? I don't think they're necessarily harmful. I think they're just, they get paid very well. Recruiting firms do very well. They usually get a significant percentage of your first year salary. And then what happens is there's like a little guarantee that if you say took a job in Florida, you took a job in Tampa, right? And this job in Tampa, and you left after 6 months, that recruiting firm would then keep the money that they got, not out of your pocket, but out of the person, and they'd have to recruit another person for free because you left within a year. So there's some consequences for the recruiting firm, so they want to make sure they're matching people to the right situation. Some of them are awesome. I mean, some of them are horrible. I still get recruiting things from people, but
I mean, generally speaking, they're okay.
yeah.
You know what I mean? You tell them what you want, they'll look for you, blah, blah, blah. But I definitely wouldn't
It's like
sign
a
it.
realtor. So when you go to a realtor and the realtor helps you find a house, you're not paying their fee. The seller is paying their fee. In this situation, it's the healthcare system that's paying their fee.
Mhm.
So they're advocating for you and they're not gonna making money off of you. Does that help?
Makes sense.
Yeah. But don't sign an exclusive with any recruiting firm.
No.
It's got
I haven't heard
emails
that
and
yet,
it's
but
like,
that's,
it's like a bunch of grammatical errors and I was like, there you go. Delete
Yeah.
it.
Are you a second year or?
I'm a third year. Yeah.
So you're done soon, right?
Yeah.
So you're looking for jobs. Is there a lot of jobs?
Yeah.
Yeah, there's a lot of jobs.
There's a lot of jobs.
It's good. It's good. I'm glad to hear that. In cardiology, there's a ton of jobs for non-invasive cardiologists, very few jobs for interventionalists, and a lot of jobs for EP. It's like it's just the way it is. Can't find it. If you want to do an intervention around here, it's going to be really hard to do cardiology. And you think, wow, 20, 30 years ago, that wasn't the case. You can't find an interventional job around here.
I mean,
I think none of us are interventional cardiologists.
That's
Sorry,
become
none of us are
interventional
interventional cardiologists.
Yeah, but like there may be a certain area in your thing that you should know about. Like, I don't know, I think crit care docs are crit care docs. I think they're just into, if you're anesthesia crit care, it might be more desirable than ER crit care. I don't know. It's just everything's different, but not sure. All right, great. Thank you.